Well, hello everyone. My name is Michel, and I would like to extend a warm welcome to all of you. Thank you for joining us today. I'm delighted to welcome Dr. Matthew Phillips, a clinical and research neurologist based at Waikato Hospital in New Zealand. And as you may have heard, as I was talking to both my friends a minute ago, we had the pleasure of hearing from Matt 2 years ago on the topic of fasting and dietary therapies in Parkinson's disease. And that was a conversation that has now been viewed over 100,000 times on our YouTube channel, which just testifies to the interest that you have in this topic. Today's session will go beyond fasting and ketogenic diets, as Matt will help us explore a broader framework for navigating and combining different therapeutic options for Parkinson's. So as always, before we begin, please note that the presentation today is for informational and educational purposes only. So if you're seeking medical advice, please consult a qualified healthcare professional, but you know that. And there will be time for questions at the end of the presentation. So if you would like to ask a question, please use the Q&A function at the bottom of your screen, the Q&A function at the bottom of your screen. Don't use the chat function, please, for questions. For those joining us for the first time, No Silver Bullet is co-managed by Mark Lambert and myself. And our goal is to share Parkinson's expertise that we're doing today and help our community make informed choices. And we share all our webinars on YouTube and on Spotify, and you will find the links in the Zoom chat at the bottom of your screen. So look for the little icon chat, and you will see basically all the details to access our webinars on YouTube and Spotify. You can also visit our website, which is nosilverbullet4pd.com, nosilverbullet4pd.com. But now let's get started. Please join me in welcoming Dr. Matthew Phillips. Matt, the stage is yours.
Okay, thanks, Michelle. And Mark, thanks for having me again, guys. It's a pleasure to be here as always. So I'll just share my slides here. All right, so hopefully everybody can see that and it's coming up okay.
Yes, perfect. It's coming up perfectly well.
All right, so yes, this talk is called Optimizing Parkinson's Essential Therapies. And I'm going to actually provide a framework on how to combine a number of different treatments, resulting in a sort of comprehensive approach to Parkinson's. And this talk is meant for people with Parkinson's, of course. So a bit of background on myself first. I'm a clinical neurologist and the director of neurology now at Waikato Hospital in New Zealand. I have bachelor's and master's degrees in biology, which I obtained in Canada. And I also have my MD and specialist training in neurology, which I obtained from Australia. And I have no disclosures of conflicts of interest. Okay, so this talk is really going to emphasize the essential. And what I mean by that is probably best encapsulated by a quote that Bruce Lee said some time ago. It's not the daily increase, but the daily decrease. Hack away at the unessential. So getting yourself onto the few best therapies is really going to be the focus of this talk. So rather than adding multiple solutions to a problem, I'm going to emphasize maximizing the few best solutions that are truly essential. And that means not just focusing on additive solutions, but also focusing on subtractive solutions to discard what is not truly essential. I think we often as doctors focus on what can I add to help this person, but it's equally important to think about what can I remove that's not helping this person, or maybe that's harming this person in some way. So the outline is pretty simple, three sort of sections. Bearing the essential in mind, we'll cover first, very briefly, a comprehensive iceberg view of Parkinson's. This is how I view the disorder, and I think it's really important for setting up the next two sections. The second section will be emphasizing how to maximize your medical treatments. That's sort of the tip of the iceberg. Those are essentially allopathic. Okay, so that means they're aimed at reducing or eliminating symptoms. But the exciting part of the talk from my perspective, or the more exciting part, will be how to maximize mitohormetic therapy. And I'll talk about what that means. And that includes metabolic therapy. Metabolic therapy being the fasting ketogenic diet protocols. That's a big section of mitohormetic therapy, but there's other things too. And this is the bulk of the iceberg, and it's salutogenic. Salutogenic means it's healing or restorative based, okay? So these are two different approaches, and I think we can combine them. We don't have to pick one. Okay, so first, a comprehensive iceberg view of Parkinson's. What do I mean by that? Well, it's very important to recognize that Parkinson's is a multi-systemic disorder. It's not just certain parts of the brain that are afflicted. It's typically diagnosed, of course, by its motor symptoms, so the tremor and stiffness and so on, but it's much more than that, as everybody here knows. There are changes throughout the brain and body that lead to a lot of these non-motor symptoms. So you get mood and cognitive problems, so depression, anxiety, problems with thinking. Some people get apathetic. There's autonomic failure, so you can get blood pressure drops, particularly when you stand up, gastrointestinal problems like constipation, urinary problems like incontinence, particularly at nighttime. There are sleep problems. These are virtually universal. Everyone has a degree of insomnia or sleepiness throughout the day. Sensory impairments are very common, so loss of smell or impaired smell, pain syndromes, and of course fatigue, sarcopenia, muscle loss, weight loss. So there's a lot to this disorder. It affects multiple systems throughout the body, and it's actually important to recognize this fact if you really want to treat Parkinson's comprehensively. Now, it's even more than this. Beyond being just a multisystemic disorder, there's a lot of converging lines of evidence in the scientific literature showing that it's a multisystemic mitochondrial disorder. And this is no surprise because mitochondria are everywhere throughout the body in almost all our cells. In Parkinson's, there's a lot of evidence of impaired mitochondrial biology. Okay, so the mitochondria are disrupted or damaged on many levels, 6 levels in particular. And mitochondria are these, there's a few hundred or a couple thousand in virtually all cells. They are the processors of cell energy and metabolism. They actually coordinate a lot of cell functions. They produce most of the energy, but they also coordinate how the energy is used by cells and throughout the body in general. So that's what a mitochondrion picture typically looks like, sort of ellipsoid-shaped little, we call them organelles. But in fact, they can change their shape, change their size. They can become long and skinny, short and fat, circular, whatever. So keep that in mind. They're quite flexible. And the details are not important here, but these are the 6 levels upon which they can be impaired. Don't focus on these 6 levels. I just put them up so you know they're there. So the impairments can occur in a sort of multifaceted manner. Any of these levels can get impaired, which will affect how the mitochondria produce energy and coordinate the flow of energy. Okay, so what things damage these mitochondria? This is super important, these triggers of impaired mitochondrial biology. Well, there are a lot. There are a lot. And this is why so many different things are probably involved in producing Parkinson's disease in people. And the process might start very early in life. It probably does. Most of these factors probably relate to the modern lifestyle. Now, toxins and pesticides and chemicals and so on are definitely implicated in this. But so is the dietary lifestyle, particularly, I think, too many meals throughout the day and high amounts of processed carbohydrates combined with fat. So it's not just the carbohydrates, it's the carbohydrates plus the fat that's the problem. A lot of people don't exercise enough, so being sedentary is a strong risk factor. Loneliness is a strong risk factor. Sleep problems before you even have the Parkinson's is a strong risk factor. And of course, for some people, genetics. Now, these triggers can all impair mitochondria directly. For example, a toxin or a pesticide can actually get in there and damage the mitochondria in a very direct manner. However, a lot of them, what they do is they force the mitochondria to adjust in an abnormal manner. The mitochondria don't just sit there statically. When they're exposed to a stress, like an abnormal diet or an abnormal activity or something, they try to adjust in your body and compensate. And if the stress is really abnormal, then they compensate in an abnormal manner along all these, one or more of these 6 levels. So that's a problem. And these triggers, it's also important to recognize they're mostly environmental. Okay, so the genetic factors can be very important, perhaps in 10 to 15% of people. But for most people who have what we call sporadic Parkinson's disease, they're not so important. Okay, so that's really important. And how do you summarize these last 3 slides? Well, you put up this iceberg view of Parkinson's, and this is how I see it, as a metabolic iceberg. So at the top of this iceberg, of course, the most obvious thing is the Parkinsonism, the tremor and rigidity and so on, that are very easy things to see. And if you do a few scans or look at people's cells under the microscope, you might see more changes, atrophy in certain brain regions, the Lewy bodies and so on. But this is only, in my mind, a sequelae or consequence of Parkinson's. The true Parkinson's disease is everything you don't see under the waterline. It's the bulk of this iceberg. And you can see there that it's mainly the mitochondria problems along those 6 levels that I am referring to when I talk about the bulk of Parkinson's disease. And these things start years or decades before the tip of the iceberg emerges, right? So there are problems before the disorder is diagnosed. And of course, at the base driving this whole process in Parkinson's are things like the heavy metals, the pesticides, the chemicals, the modern dietary lifestyle, physical inactivity, social isolation, poor sleep, and in some people, those mutant genes. Okay, so this is a good comprehensive way to look at Parkinson's. It keeps things simple, but it's all encompassing. And it's really, again, I can't emphasize it enough, is that what we call Parkinson's disease is mostly in the bulk, and it's mostly hidden, and everything that people diagnose it with it emerges later. Okay, so second section, how to maximize medical treatments using this iceberg approach. And this is really aimed at treating the top or the tip of the iceberg. So there are a lot of medical treatments in PD, okay, and these generally treat the tip. They're largely allopathic. Super important to recognize that. The aim is to suppress or eliminate symptoms, which can improve quality of life, so that's important, but they're not about restoration or healing. Okay, there's a lot. So the best by far is levodopa, and it comes in 2 forms, immediate and extended release. I'm going to talk a little bit about that. But there are also dopamine medications that aim to sort of increase dopamine or mimic dopamine in other ways. There are symptom-specific non-motor treatments. There are a lot of off-label medications and device-aided treatments. I'm just going to go over a few of them, some of the ones that I most commonly get asked about in my Parkinson's clinics. And I think there's a deal to be said about these. So what these all aim to do, though, essentially, is improve function and quality of life in the short to medium term, months to years, okay? But the effects generally wane with time. Guidance is mandatory, okay? I think working ideally with an open-minded neurologist, if you can find such a person, is really crucial because some of these treatments interact with each other, some of the off-label medications included. And so you just have to be careful before starting any of these things and make sure your neurologist knows about it. Okay, so a bit on levodopa. Now, levodopa is the best medical tool we have for Parkinson's, bar none. It's been the best for over 50 years. It's a dopamine precursor, so it replaces the dopamine that is low outside of the cells in Parkinson's, not inside, as some people may know, maybe. But it's mostly used to improve motor symptoms, and there are 2 main forms of this medication, which you may not be aware of. There's an immediate release, or IR form. It starts working in sort of 20 to 30 minutes. It's fully absorbed, and it lasts for about 3 to 4 hours. Then there's an extended release one, or controlled release form. And this takes maybe an hour or 90 minutes to start working maximally, and it's less absorbed, and it lasts a couple hours longer, so sort of 5 to 6 hours. And good regimens, I always try to use combinations in people if I can, because they're good at different things, right? So during the daytime, the immediate release levodopa is really useful. And one great regimen, it's called Cinemet in New Zealand, is to use a 100/25 milligram tablet at, say, 7 a.m., 11 a.m., 3 p.m., 7 p.m. It's nice to have the same amount of time between each tablet, so in this case, 4 hours. And that 7 p.m. one is to help induce sleep. You need levodopa at nice levels to get to be able to fall asleep. And then at nighttime, you can add in an extended release tablet, a 200/50. It has to be higher because it's absorbed less, at, say, an hour after you take the last immediate release. So this one would be at 8 p.m. This one will help you stay asleep throughout much of the night. And then if that person wakes up between, say, 1 and 5 a.m. and they have a hard time getting back to sleep, taking one more of the immediate releases to get back to sleep and get those early morning hours of sleep good. That's where a lot of people go down, is they don't have good sleep, sort of 4, 5, 6, 7 a.m. Then this is a nice strategy for most people, not everyone, but for a lot of people, this is a good strategy. So something like that, it's important to cover the day and the night. Now, how do you enhance levodopa delivery? A lot of people take this medication, but they're taking it in a way that makes it difficult for it actually to be working at 100% effectiveness. So we have to maximize what we call its bioavailability, the ability of it to get into the brain and do its thing. And there's a few factors that can affect that. So one thing here is, definitely we have to think about protein. And the effect of protein. Protein interferes with levodopa. They sort of compete for the same receptors in the gut. So I like to have, I've stretched this rule out as the years go on. I like a 1 and 2 rule for meal timing. So it's really important not to have a meal an hour before your medication if possible, and not to have a meal within 2 hours, not to have the, it's important not to have levodopa within an hour of a meal, and it's important not to have the levodopa 2 hours after the meal. So this is called meal timing, and this means you don't want your levodopa and your meals to be at the same time because they'll interfere. So take that levodopa at least an hour before the meals and at least 2 hours after the meals if you can. And the second thing is to recognize that it's good to take it with water. Some things like dysphagia, swallowing problems, and gastroparesis, bloating can interfere with absorption. So take it with water only. And if you have trouble with swallowing or gastroparesis, try some carbonated water with a bit of sparkling water, and even coffee. Coffee is probably a net benefit in Parkinson's disease. The opinions vary, but I think coffee has a number of benefits. It's probably able to help stimulate stomach. It definitely provides a mild dopamine boost in of its own, and it's probably a net benefit in Parkinson's. Of course, if you don't like coffee or you don't feel well on it, that could alter that statement for you. Now, it's important to minimize adverse effects of levodopa as well. So a lot of people get nausea or postural hypotension, blood pressure drops. The way to get around this, sometimes the doctors will start the levodopa at too high a dose, and you get a lot of nausea or blood pressure problems, then the person just stops it, right? So start low and go slow. Maybe even half a tablet, 1, 2, 3 times a day for a week, and then increase it weekly slowly. And you can take an anti-nausea medication like ondansetron before meals to get you over this, because the body will adapt and get more used to it if you stick with it, usually. For the blood pressure drops, it's really important to make sure you're getting enough water, at least 1 liter of water per day, and salt. A lot of people have adopted the low salt mantra too much, and you need at least a teaspoon of salt a day in order to keep your blood pressure up. So it's not just water that keeps up your blood pressure, it's also salt. Now, beyond levodopa, there are a lot of dopaminergic medications, okay? These all are other options for treating the motor symptoms, and they all aim to increase dopamine activity in some way. There are dopamine agonists like ropinirole and pramipexole, MAO-B inhibitors like selegiline and rasagiline. Rasagiline is generally better. COMT inhibitors, tolcapone and tecapone. These are older drugs. I almost never prescribe these drugs anymore. Amantadine is a bit of a wild card. It helps in some people quite a bit, doesn't help others at all. Now, the thing about these is they all are pretty good, but rather than just throwing these on too early, it's best to maximize the levodopa that you're on so that you get the maximum effect of that before you start adding on too many medications and get into this thing called polypharmacy. So the best tool is still levodopa. It's better than all of these. And in most people, these dopaminergic medications should be used as adjunctive therapies and only after the levodopa delivery has been absolutely optimized. So that does not mean just going and getting the dosage increased by your doctor. It also means optimizing the dosage intervals, the balance of the formulations between immediate and extended release, and the meal timing. Okay, it's so important to get all these things right before you jump into these other tablets, in my perspective. And I find most people can go on levodopa for years and years without adding anything else if they do it right. Now, non-motor treatments for the non-motor symptoms can also be done in many other ways. There are ways to treat them each specifically in a symptom-specific manner. These sometimes work, but they sometimes don't. So depression, anxiety, of course, you can use antidepressants, anxiolytics, cognitive behavior therapy, things like that. Postural blood pressure problems, you can use antihypotensive medications. That's one thing you can use. They do have side effects. Overactive bladders, you can try these antimuscarinic drugs. They often don't work too well. Sleep and muscle relaxation, high dose magnesium. I usually go with 600 milligrams at bedtime. Some people need that much. Some people don't need that much, but some people do. You try it for a month and see if it's working before you decide whether or not to stop it. REM, sleep behavior disorders, that's when a person is talking in their sleep, punching in their sleep, kicking in their sleep. The best drug for that by far is clonazepam. A bit of clonazepam at bedtime can help a lot. Now, again, these may or may not work. They're worth trying to improve quality of life, right? But there may be a better treatment for many of these non-motor symptoms, and hint, hint, it's probably something to do with ketogenic metabolic therapy, which I'll talk about soon. Okay, there's off-label medications, and a lot of people are trying these now, and there's a lot of excitement being stimulated about some of these. So most of these are based on theoretical and preclinical evidence. So that means evidence from cell cultures and animal models. There are a few human studies. They all generally aim to do the same kinds of things. They aim to reduce oxidative stress or free radicals in the body and inflammation in some way. They all aim to protect neurons from damage in some way, so they're called neuroprotective. They all aim to enhance mitochondria in some way, which is nice. And most of them aim to improve motor and non-motor symptoms in some way. What am I talking about here? I'm talking about things like mucuna pruriens, so velvet beans, which is a natural source of levodopa. I'm talking about the cannabinoids, so CBD oil and THC. I'm talking about coenzyme Q10. High-dose thiamine is a hot topic for a lot of people. Nicotine patches can be very helpful for some people. N-acetylcysteine is an old drug, but it's developing interest in Parkinson's. And of course, the current one that's of most interest to some people is probably methylene blue. Now, there's rather weak clinical evidence for all of these in people with Parkinson's, okay? And I'm an evidence-based guy. I'm not a I don't try to sell people stuff or play things up more than the evidence that they have behind them, but they are all worth trying, okay? Absolutely. Just inform your neurologist if you're going to try them. I personally think these four on the right have a little more evidence behind them and a little more interesting to me, particularly methylene blue. But really, at the end of the day, the evidence is inadequate for all of them, and the best thing is to try each of them one at a time for a month before you decide yourself. So, and I'll talk about that more in a little bit. Okay, there's also device-aided treatments. So for these options, there's a bit more clinical evidence in people with Parkinson's, actual humans. Most of them are aimed at alleviating the motor symptoms and to a lesser extent the non-motor symptoms. Most of them aim to alter neuron firing patterns, and that can help the motor symptoms. Some of them indirectly enhance mitochondria as well, which is good. The major exception is red light therapy. That probably aims to directly enhance mitochondria, so I probably favor that treatment a little more than some of the others. So things like apomorphine infusions, this would be one of these device-aided treatments. It injects a sort of levodopa precursor subcutaneously into the skin. You walk around, you have a little pump. A lot of neurologists are familiar with that. Deep brain stimulation, of course, is a highly invasive surgical operation that can help a lot in some people. Focused ultrasound is something similar. You use an ultrasound which you apply externally, and you ablate or destroy certain parts of the brain that are causing problems. Now, those three treatments are a little more permanent or have a little more invasiveness to them, shall we say, than the next four. There's transcranial stimulation. That can be magnetic or electric, direct currents. There are cueing devices, so you can throw different cues that would be like visual things or auditory things or tactile things like vibrations at the brain. So this picture shows boots that send vibrations, and you can sort of help train the brain to make the movements for that person better. And a subset of these cueing devices, which are quite popular at the moment, are these vibrotactile devices. You take a little sort of stimulator that sends vibrations, and you can put it on various parts of the body, and it can help and train your brain and improve your performance that way. So that's kind of neat. And of course, red light therapy, which has that's the one that has the most interest. I get asked the most about amongst these devices in the clinic. Now, again, there's stronger evidence for the infusions, the deep brain stimulation, and the focused ultrasound probably than the other four. But I think I would say it's very wise to try the other four devices first, these ones. Why? Because they're non-invasive, they lack permanent effects. So why would you jump to the ones on the left if you haven't tried the ones on the right? So, and again, you know, I think you could try any of them. You give them all 1 month for each and decide at the end of the month if you've improved or not. That's the best way to do it. So let's talk about subtractive solutions here. One slide. We've talked about additive medical treatments. Now let's talk about subtractive solutions. It's so important. I see this all the time. It's a bit irritating. Polypharmacy. Now, polypharmacy means only 5 or more medications at a time. It's not a lot of medications. And if you think how many people you know or yourself are on 5 or more different medications, that's a lot of people. So combinations of medications can be beneficial, but they can also lead to problems because of interactions. So try to avoid this. In addition, the interactions can lead to more adverse effects. So that's one reason that polypharmacy is bad. Another reason is, if you're on so many different things, you're spending more time and more money on these things. And some of these things may not be helping you that much. And it's hard to tell when there's so many drugs in the mix. And I think one of the biggest things about polypharmacy is when you're on like 15 different tablets, it reinforces your brain, even consciously and even subconsciously, that I am a sick person. I need these tablets. I am dependent on the medical system for my tablets or on these supplements or whatever they are. So it reinforces this sick role, which makes you dependent, defensive. And I like my patients to be self-empowered and proactive and sort of take charge of their condition. That results in better outcomes. So basically, each of these medications and devices should be definitely enhancing your brain function and your quality of life in some way. And you need to know that they are. So try each of them one at a time, okay? Like a scientific experiment. Give each of them a sufficient amount of time. I think 1 month is enough for most of these. If you don't know if it's helping you by the end of the month, then it's probably not. So if there's no definite improvement by the end of the month or you're not sure, just stop it and try something else. Now, unless 100% crucial, I would say all the drugs, other drugs you're on, minimize the use of these ones in particular. Statins, anti-epileptic drugs, particularly valproate, opioids, beta blockers, antipsychotic medications, antiemetic medications, particularly metoclopramide, and proton pump inhibitors. All of these have some pretty decent evidence. They impair cognition or give you more fatigue, they sap your energy levels or something like that, something that's not good for a person with Parkinson's, okay? So if you are on any of these, I'm not saying stop them, but just ask your doctor, can I reduce this medication? Can I eliminate this medication, please? They may be resistant, but it's good to open up this discussion and see how many of these things you can reduce or stop to avoid polypharmacy. Okay, that's the medical treatment, section 2, done. Now we're going to talk about section 3. This is the most exciting section to me, and I think this is where the future of Parkinson's really lies from a therapeutic aspect. And of course, this is maximizing the mitohormetic therapy, which includes metabolic therapy, and this is going to treat the bulk of the iceberg, the mitochondria. So what is this, mitohormetic therapy? Well, this treats the bulk and the base of the iceberg. It's salutogenic, which means it's healing or restorative based. The aim of mitohormetic therapy is to restore or heal mitochondria by activating what we call mitohormesis. This basically means when you put a challenging stress to mitochondria, and then you follow that with a nice recovery, they get stronger and healthier and better in the long term. Now, it's tricky. The stress can't be too weak, but the stress can't be too excessive, right? You want to make them a little bit damaged with the stress, but not so much that you destroy them. And in terms of the recovery, okay, the recovery can't be too short. It has to be complete and allow them to fully recover. But it can't be too long either, right? If you wait too long, then they'll start to decline because they're not getting stressed anymore. So this is a very tricky balance between stress and recovery, and this is what I mean by mitohormesis. This is a very old concept and a very powerful one, I think, in Parkinson's that we really need to explore more. The modern lifestyle factors that we can change to improve mitohormesis, these are the top 5. This is not all of them, but these are the top 5. Industrial toxins, I'm going to talk about. Dietary lifestyle, and that is about ketogenic metabolic therapy, or KMT. Cognitive behaviors, physical behaviors, social behaviors. Now, the stressor phase in each of these is different, okay? So, of course, exposure to toxins, the feeding part of the dietary lifestyle, which a lot of people talk about. What is the best diet? How do you stimulate your brain cognitively? Your exercise program. A lot of people talk about what's the best exercise program, and psychosocial engagement. But it's equally important to talk about these recovery phases, okay? So what are you doing when you're not eating? What kind of fasting protocol you got? We don't talk about that as much. How do you recover from your cognitive stimulation and your exercise program and your psychosocial engagement? What are your recovery protocol? We don't talk about this that much. Sleep and deep rest protocols and things. So I'm going to give equal emphasis to the column on the right. And the aim of this mitohormesis is to improve function and quality of life in the medium to long term. I mean years to decades, not just months or so. But in fact, mitohormetic strategies can make you a little worse in the first few weeks or even months when you start them, right? That's kind of the point. But if you stick with them in time, they can improve you. And guidance for these, I would say, is strongly recommended, particularly when you start. When you get good enough at a lot of these things, you no longer need the guidance, but that takes at least a few months to become an expert yourself. So I would say it's very good to have a guide initially for these kinds of things. Okay, toxins. One slide on toxins is important, but I'm going to dedicate one slide. Now, small amounts of toxins, even things like lead, there's evidence that that's actually better for you than no exposure. Okay, so I'm going to say toxins are not always bad. If you have light exposure and then a nice rest, mitohormesis can allow your mitochondria and cells to get stronger. Okay, it sounds counterintuitive, but it's true. However, that said, most people suffer an excessive chronic exposure to industrial toxins, and that's just because of our modern lifestyle. The ones most strongly associated with Parkinson's are heavy metals, particularly lead and mercury, homes covered with old paint from the pre-80s, drinking water from old pipes from the pre-90s, high mercury fish such as marlin, tuna, and others in that diagram, dental fillings that have been there a long time, some of them have mercury in them. Pesticides, of course, this is a strong risk factor. Non-organic fruits and vegetables. See that chart there? That's the dirty dozen. Those are the ones, most of them are fruits. They have the most sort of pesticides on them when you buy them at the market. So it's good to go try to avoid these a little bit or go totally organic. Some processed foods have pesticides in them too. Solvents. Solvents is a big one. Degreasers, paint thinners. Don't use dry cleaners. And some drinking water. Okay, so make sure you have a proper filter for your drinking water. These are all things that are associated with Parkinson's reasonably strongly. Now, it's important to note the evidence for these things is from observational studies. So these show associations. So none of these have actually been shown to be truly causal, but I think the bulk of the evidence is strong enough to say that it is wise to reduce your exposure to these chronic, to reduce your chronic exposure to these toxins, particularly if you are exposed to any of them on a daily basis. Dietary lifestyle now. Why would we be interested in ketogenic metabolic therapy or KMT? This is one slide. It's about the evolutionary reasons for ketogenic diets and fasting protocols. I know some people do not believe in evolution. I apologize. Ignore this slide if you're one of those people. But in my perspective as a biologist, I think evolution is a very powerful theory. And we have to have, if the treatment is going to be that good, it has to have an evolutionary reason. Modern lifestyles place us in constant physiological, what I call glucosis. Our brains and bodies are running on glucose, which is a simplest form of sugar and carbohydrate virtually all the time. This is not normal, okay? This is sort of a post-agricultural thing. For 2 to 3 million years, our hunter-gatherer ancestors were mostly in ketosis, running on a different molecule called ketones, which comes from fat. Now, nearly all of them ate a ketogenic or lowish carb diet. There's an incorrect view that these are our ancestors were not on these diets. These are the ancestral diets for virtually everyone around the world, with rare exceptions, such as the Hadza people. Those people had a lot of carbohydrate, but they ate a ton of fiber as well, which can mitigate a lot of the bad effects of carbohydrates. So if you look at the best studies looking at modern hunter-gatherer peoples around the world, you can see people in the northern latitudes, the tundra and the northern coniferous forests, they have very small amounts of carbs in their ancestral diet, and they are basically on a ketogenic diet. Now, most other people are on a low carb or low to moderate carb diet. The people with the highest amounts of carbs are people in sort of the desert grasslands and maybe the tropical grasslands, maybe up to 30 to 35% carbohydrate in their diet. However, this is still lowish carb, lowish to moderate at most. It's nothing like the modern diet that most people eat today. These people also ate intermittently. They did not have 3 meals a day, 4 meals a day, 5 meals a day. 3 to 6 is sort of the average. So they did a lot of fasting. They would have been in ketosis most of the time. Parkinson's was rare in our hunter-gatherer ancestors. Less than 10% of adults died from the lifestyle disorders. That's your heart disease, that's your cancer, that's your Alzheimer's and Parkinson's and so on, okay? Very, very rare, these disorders. And the modal or most common age of death, this is another incorrect perception. I don't know how it gets propagated, was that they died very young in their 20s. This is incorrect. The common age of death in modern hunter-gatherers, 72 years. If you look at the common age of death the world over today, it's 70 to 75 years. It's basically the same, okay? So you have to know this information when people put up these counter arguments so that you can actually counter the incorrect sort of perceptions that are out there. Now, ketogenic metabolic therapies, ketogenic diets, fasting protocols are just strategies that induce our most natural state of ketosis and activate mitohormesis. Okay? This is a mitohormetic activating lifestyle, unlike the modern lifestyle, which is the opposite. Okay, so what do we mean by these ketogenic diets? Ketogenic diets is a nice stressor phase when you're looking at this from a mitohormetic framework. In the context of mitohormesis, the standard diet, the problem, you can look at this really simply. The main problem with the standard diet is that it exerts an excessive stress on mitochondria. It's high in fat and carbs. It's like 50% carbs, 30% fat, and a bit of protein as well. This leads to what we call a metabolic gridlock. The mitochondria can deal with high amounts of fat if carbs are low. They can deal with high amounts of carbs if fats are low. But they can't deal with high amounts of both. It's very difficult, and it results in a lot of free radical production and damage. Low carb and ketogenic diets really mitigate this gridlock by increasing fat but keeping carbs really low. And this results in a nice challenge for the mitochondria, but doesn't overwhelm them and injure them. Okay? Ketogenic diets are just high fat, so at least 70% of energy intake, low carb, less than 50 grams daily, adequate protein diets. I like to think of them as strategies rather than diets, because the whole point is to get you into ketosis, and it just happens to be a diet. They're highly flexible. Okay, they can be implemented many ways. This is a nice ketogenic diet food pyramid, which will seem very unfamiliar to people who grew up in the 80s and 90s. They can be omnivore, carnivore, or vegetarian. This one is a meat-heavy omnivore, which I think can be very good for a lot of people. So the base of this is meat, okay, with butter and maybe some olive oil. And then you have green vegetables in the middle. And then you have a little bit of nuts and seeds and a few berries and stuff at the top. That's a very different kind of food pyramid to the classic one that many people grew up with. They can be tailored to any ethnic cuisine. They cross cultural barriers because the ancestral diet for virtually everyone is ketogenic or low carb. In general, I think you must avoid keto sweets. Only eat keto sweets on special occasions if you do these, because the sweet taste itself can hijack what you're trying to achieve, and that can really affect a lot of people. And due to the higher protein and fat, when you're taking levodopa, I adopt a 1 in 3 rule. So take your levodopa at least an hour before the meal and wait at least 3 hours after a ketogenic meal if you're going to have the levodopa, because the higher fat and protein will sit in your stomach a little longer. Now, what's the recovery phase for the dietary lifestyle? It is, of course, fasting. That is the best one in the context of mitohormesis. Another problem with the standard diet, when you have 3 to 6 meals a day, you're constantly hammering the mitochondria with nutrition. Even if it's a ketogenic diet, it's a lot. So it's important to realize this leads to a chronic nutritional influx, and this is hard for the mitochondria. They need a rest period. That's when they recover the best, is when there's no nutrients coming in. Fasting protocols mitigate the influx by providing a nice, complete recovery phase, okay? And fasting just means abstaining from food and drink. Some people abstain from both. This is called dry fasting. I would not recommend this unless you have guidance. They take no water and no food for a certain period of time. It's a little harder, but arguably more powerful than other forms of fasting. But most fasting, it means you're fasting at least 12 hours, okay? And I think the best protocol for most people is water only, maybe with a bit of limited tea or coffee. Again, coffee can be nice in Parkinson's. The fasting can be intermittent. That means fasting that usually is on a daily basis. So 16 hours of fasting, 8 hours of feeding, or 20 hours of fasting, 4 hours of eating. TMAD means 2 meals a day. OMAD means 1 meal a day. I like TMAD and OMAD. Personally, I use OMAD myself almost every day. The fast can be prolonged, so they can be 2 days or longer. Those can have uses. Definitely don't try those without guidance, though. Further mechanisms of ketogenic metabolic therapy, diets, and the fasting. I could talk about a lot of complex things here, but just to give you an idea for the sciencey people among you, there's growing evidence amongst animals and humans that these ketogenic metabolic therapies can rescue brain and energy metabolism in neurodegenerative disorders like Parkinson's. So they generate the ketones that are a better energy source, as we know. There's all these other wonderful effects, and you can get big complex diagrams like this. But when you see these big complex diagrams, if it's a good diagram, it's important to recognize that at the middle of all these processes, coordinating the whole thing, is, of course, the mitochondria. Okay, so again, it's mitohormesis. That's the key process that leads to enhanced mitochondrial repair and recalibration long term, rather than focusing on ion channels or this certain molecule or this neuroprotective effect. Just look at the big picture, go, it's the mitochondria. We heal them up, a lot of these other things will take care of themselves. Okay, I'm going to give you a little bit of evidence behind ketogenic diets because it's so important to know this evidence when you talk to people. The first clinical trial of a keto diet came out about 20 years ago by Dr. Ted Van Iddeley. And this was a single-arm clinical trial. that caused a lot of interest. What he did was he actually looked at a hyper ketogenic diet. He only had 7 people with Parkinson's, 4 weeks only. It was 90% fat, 8% protein. So super high in fat, very low in protein and carb. And the motor scores improved by 43%. So down is better. And you can see that the baseline, they had a UPDRS score of about 23. And it reduced by 43% after just 4 weeks. So the motor symptoms improved by almost 50%. Very, very good, you say. However, several important weaknesses to consider before getting too excited. There was no blinding of the assessors, so that everyone knew that these people were on these diets, and that might have affected how they were assessed. There's no control group. This thing called the placebo effect is very powerful in people with Parkinson's. That's where if you feel you should get better, you can get better physiologically, and that can improve you by about 20% on its own. These were people on a very low protein diet, so their levodopa would have been absolutely maximized because the protein was taken down. And if they only had a 70% completion rate over 4 weeks, so this was a pretty tough one to stick to. And if only 70% can make it to the end of a month, then long-term adherence might be tough. So this was still a great little trial, and this is what stimulated my interest and resulted in the first randomized trial of a keto diet in Parkinson's about 15 years later that we did. This is a single-blinded, double-arm parallel trial, and what we did is we compared a really good, healthy, low-fat diet with lots of fiber, no ice cream, no beer, or any of that stuff, with a modified keto diet in 47 people. We did it over 8 weeks. We just doubled the amount of time. If I'd had more money, I would have done longer. We kept the protein at a decent level, 1 gram per kilogram in both diet groups. We had a decent completion rate of 86% over 2 months, and the ketones were mild to moderately high. That was pretty good. 1.2 millimole per liter is a good level of ketosis. The most important finding from this trial was that the non-motor scores improved in both groups, multiple non-motor symptoms, particularly urine dysfunction, pain, fatigue, daytime sleepiness, and cognitive impairment. And so this was a nice blanket therapy for non-motor scores. And a lot of these ones don't respond too well to the levodopa and other medical treatments. So here's a graph showing low-fat in blue, ketogenic diet in red. Down is better. And you can see that the low-fat guys did improve by the end of the 2 months by about 10%, but the keto diet improved by 40%, and they were probably gaining trajectory as well. The motor scores improved in both groups by about 20%. So again, both of them were on a better diet than what they were on before, probably, and also the placebo effect might have affected both groups there. I have to say, though, that the keto group improved a lot more in the second 4 weeks, so I think it was gaining steam. Motor complications improved in both, 18% in the low-fat group, 32% in the ketogenic diet group. It wasn't quite statistically significant, but almost, so we didn't make too much of that. I should say those non-motor scores, too, that was also a clinically meaningful change, as in it made a big difference to people. It was very apparent, the improvements. And adverse effects. The most common adverse effect in the keto diet was a transient worsening of the motor symptoms. For the first few weeks, a lot of people got a little worse before they got better. So that's what I mean with these things. A lot of people will get a little worse before they get better. Now, things I was worried about, bloating and constipation, I was really worried about with the keto diet group. These were non-issues. So there's theory that says people with Parkinson's have constipation. I'm so worried about starting a keto diet. But reality, these were non-issues. We just made, I think, ensuring the water intake and the salt intake were high were important things, maybe, but at the end of the day, constipation improved in most people in the keto group. The main weakness of this trial, it was still relatively short at 8 weeks. And since then, there have been a few more trials of keto diets in Parkinson's. I'll just talk about 3 of them. So 6 years ago, Krikorian's team looked at 14 people, 8-week-long keto diet. Weakness of this trial, their ketones were pretty low, only 0.3, Now, another group did another study 1 year ago in 16 people, looking at a regular diet versus what we call an MCT keto diet. Interesting study. The main weakness of this, it was only 3 weeks long, so very short. And then Melanie Tidman did one a year ago as well. She looked at 7 people, a nice long study, 24 weeks. However, she didn't have a control arm. So all these studies have strengths and weaknesses. What's really nice to see, though, is all of them in addition, along with ours, showed improvements in non-motor symptoms. Now, when you get multiple investigators around the world all showing the same thing in this condition, you can trust those findings, okay? If it was just us or just this other group showing it, then you go, oh, well, you have to replicate it by other groups. It's been replicated, okay? So keto diet absolutely improves multiple non-motor symptoms across the board. It has not yet been shown to convincingly improve the motor symptoms, okay? Not in our trial, not in any of these trials. I think if we're gonna get there, we need longer studies and maybe even throw in a bit of fasting protocols and things like that to get this, okay? But right now, it has not actually been shown convincingly to improve motor symptoms yet. Carnivore ketogenic diet. I get asked about this one. This is interesting. So there's a growing interest in carnivore diets. That's in properly done, meat, eggs, and butter, okay? Now that sounds very Spartan, and it is, but most people turn to these for health reasons. The food pyramid is pretty basic. The bottom is meat, a lot of red meat. The middle, well, it's meat again, maybe some butter and eggs. And what's at the top? Guess what? A little bit more meat. Okay, so this is basically, like I said, meat, eggs, butter. Now this can be very good, okay? But for brain health, it knocks the carbohydrates down to zero essentially, and it's so simple to follow. It's important to recognize that for Parkinson's, you need to make sure the fat is still 70% or higher, right? A lot of people go on these carnivore diets for muscle bulking and things like that, and they can go with higher protein, lower fat levels. But for Parkinson's and brain health, we need the fat. And I think you can permit coffee. Coffee may be ideal for the dopamine boost. Limited amounts of herbs and spices are okay. So, you know, you can throw in a little bit of extra. You got to watch out for protein interference if you try this one, right? There's a lot of protein and fat. So I adopt a 1 in 4 rule. Do I have any evidence for this? No, but it sounds very reasonable. So wait 4 hours after any, you know, if you have a tomahawk steak, wait 4 hours before you have your levodopa, if you can. That would be ideal. Okay, subtractive solutions. Really important to avoid having too many ideas, false ideas in your head about dietary therapies, and avoid getting confused. When someone says, why are you on a keto diet? Why are you doing fasting? And you have Parkinson's, your answer is, I don't care about weight loss. I don't care about any of these other things. I'm doing this for mitohormesis and brain health. That's why you're doing it. Mitohormesis, the ketogenic diet, confers a nice challenging stress. Every time I eat, the feeding phase confers a nice challenging stress on my mitochondria, and the fasting allows my mitochondria to recover. That's why. For my brain, both of these things generate ketones and have all those nice effects that I showed you on that complicated chart that are good for metabolism and neuroprotection. That's why you do these things. So don't forget that. Now, if you're still confused or unsure, try the following. Don't jump to a keto diet. Try a low-carb diet first. That's 50 to 100 grams daily, or even up to 150 grams daily. And very importantly, keep this LDL rise in context. Some people, not everyone, but a number of people have an LDL rise, LDL cholesterol, okay? Now, that is often a huge source of concern, particularly for their doctors. But you have to balance this with all the benefits, okay? Even if a LDL rise is bad, and in the context of a keto diet, I'm not convinced that is the case. Even if you get it, think about this. If you were overweight, you've probably lost weight. And more important, when you look at the cholesterol profile, is this triglyceride to HDL ratio. You want the ratio of triglycerides to HDL to be ideally less than 2 and really ideally less than 1. Your triglycerides really ideally should be less than HDL. And this is a more powerful and important marker of heart disease than the LDL level, okay? Blood. I can't see it because of the thing, but I think things like blood pressure and HbA1c, they improve. So if your blood pressure goes down and you know, if you're pre-diabetic and you go into the normal range, or you're type 2 diabetic and that improves, those are also wonderful benefits that you get with these things. So keep the LDL rise in context. Fasting, you don't have to start super hardcore. You don't have to go to 1 meal a day or a 5-day fast or whatever right away. Start with a mild intermittent fasting regimen. Do it every day. 12 and 12 is a great way to start. Ensure that you have 12 hours of fasting every day, and that includes your sleep period. That's not hard. That's eating last meal by 8 p.m. and then not having breakfast till 8 a.m. That's very easy. Do that every day. It's compounding interest that's going to get you the gains. Don't believe myths. These do not damage the liver. They do not damage the kidney, okay? No matter what people say, these are like little studies in kids on very powerful, very different classic ketogenic diets from decades ago that, some of them showed these effects. This does not happen in else. I've never seen either of these things go bad. Supplementation is not necessary on a good diet. Even a carnivore one, you're gonna get all the nutrition you need if it's done properly. You don't need to supplement. There's no vitamin deficiencies. You're not gonna get scurvy. Try each new dietary change one at a time. For the dietary therapies, 3 months. 1 month isn't enough. You need at least 3 months, okay? So medications, 1 month is enough. For these, they take longer, and you often get a little worse before you get better, 3 months. And super important, think of diet as a strategy. If you're on a keto diet, maybe it's a Mediterranean keto diet, or maybe you're trying, the MIND diet is good. You can make both of these things keto by just increasing the fish and olive oil in the Mediterranean and MIND diets, removing the fruits and grains. And then when your doctor asks you, what diet are you on? Oh, I'm on a Mediterranean diet, or I'm on the MIND diet. Oh, great job. You just don't have to say it's keto, okay? And then they'll be fine. If you say it's keto, some of them are gonna have the stigma pop up in their head and go, oh, that's bad. So, that's one way to make it nice and easy when you're talking with your doctor. Almost done. Now, a couple last slides on the cognitive, physical, and psychosocial stressor phases. In the context of mitohormesis, you have to emphasize challenging but not excessive stressors. So cognitive stimulation, prioritize cognitive activities that are short, relatively short duration, like an hour, a couple hours, sustained attention. They require a lot of attention and focus and concentration. This induces neuron remodeling. Chess is a good example, a couple games of chess. Exercise, short, intensive exercise. So even an hour of intensive exercise will damage the mitochondria. We know that, but they recover, right? When you have a good recovery protocol. So structured Parkinson-specific exercise programs are the best. Walking is not going to be enough. Walking's great, but it's not going to induce mitohormesis to any significant degree. Okay, so it has to be an actual focused exercise program. But you don't want to go crazy and become a CrossFitter, 6 days a week. That's too much. Psychosocial engagement, prioritize short, engaging social activities, okay? They don't necessarily have to be really good activities. We know that even acute psychosocial stressors damage mitochondria, but the mitochondria recover if you give them a good amount of time away from the psychosocial activity, okay? So that being said, it's good to have supportive networks and relationships in there as well. With sufficient recovery, all these stressors induce long-term cognitive, physical, and psychosocial benefits. And this is supported by interventional studies of older adults, including people with Parkinson's, particularly the exercise. The exercise has the most evidence. Now, recovery phase is just as important. Don't just think about my mental stimulation, my exercise program, my psychosocial stimulation. How are you recovering your body and brain from that, and your mitochondria? Sleep is a mitorestorative recovery strategy. This enhances your mitochondria. You've got to prioritize sleep. Adequate sleep opportunity is huge. Providing sufficient sleep time every night, okay? You got to give yourself 8 hours, 9 hours, whatever the amount of time is you need every night. Dedicated and optimized environment. The room must be dark, quiet, and cool, and it's basically mainly for sleep. Sleep hygiene measures are super important. So there's a lot of these. You can look them up, but things like getting your morning sunlight for 20 minutes every morning, that'll help reset your clock and make your next night of sleep better. Avoiding coffee, as much as I love coffee, don't have it within 8 hours before bed. Avoiding meals 3 hours before bed, if you can, is helpful. And avoiding screen time, TVs, phones, all those things at 1 to 2 hours before bed. This is going to help your sleep. Beyond sleep, you can do deep rest protocols throughout the day, okay, and to help you get to sleep when you need to. Deep rest is this awake sort of recovery strategy where your body is awake, your brain is awake, but you've induced many of the physiological benefits of sleep in your body, okay? That's the idea behind these things. This is great to deal with chronic stress. And this leads to profound cognitive, physical, and emotional relaxation. So contemplative practices, we know this works in Parkinson's. Breathwork, mindfulness, meditation. You don't have to join a hardcore program with these. You can go online, Google these non-sleep deep rest protocols or yoga nidra protocols, even better. I love yoga nidra. I use them myself, used it last night. And these things are great. Someone will take you through some breath work or mindfulness stuff or meditative stuff for 20 minutes, 30 minutes, an hour. And it really is good. I suggest you try it if you've never tried those before. Also, making sure you have complete recovery. If you have a particularly intensive cognitive session or exercise session, psychosocial session, make sure you get recovery. Exercise, for example, 2 days a week is absolutely adequate. If you're doing intensive, good exercise for 30 to 60 minutes, 2 days a week is good. You need 3 days to recover, okay? 4 or 5 days or 6 days of exercise a week is, in my perspective, if it's intensive, it's too much. It's gonna overall damage your mitochondria. And this is supported by interventional studies in adults, some of whom had Parkinson's. Okay, last, most essentially, if you take nothing else from this talk, the most essential thing, none of what I've said matters if you don't have meaning and purpose in your life. Meaning is what matters most to you in life. It gives you a sense of significance. Purpose is how you contribute to that. That gives you a sense of direction. You've got to have these. If you don't have them, sit down after this talk with a pen and paper and write them out and think about them. Once you figure this out, you can determine your specific goals and actions. And I like to divide goals into 3 kinds of things: A goals, B goals, and C goals. A goals, most people do these. Those are goals you know you can achieve with some effort. So you want to buy a car, you got to wait and save money for 2 or 3 years, and you buy the car. It's hard, but you know you can do it. B goals are goals you're not sure you can do them. You think you can achieve it, but you're not sure. So maybe this is like starting a company. Give it 5 years, a lot of time and effort, and it still might fail, but you might be able to do it. You're not sure. The really, really great ones, I would encourage everybody here to have one of these, is a C goal. The goals that seem impossible to achieve. It's because they're impossible that you have to have it. Okay? The point of the goal is not to achieve it. It's actually to grow as much as you can in trying to achieve it. You've got to have a C goal. That'll keep you waking up excited every day. So the purpose of that might be, I want to cure or stabilize my Parkinson's. Maybe that's a wonderful C goal, and you can implement many strategies to try and achieve that. The pursuit of these goals in of itself will lead to a sustained release of dopamine, okay, particularly the C goals, provided you're making some sort of slow progress. So I encourage you to think along these lines. Okay, conclusions. By viewing Parkinson's comprehensively as an iceberg, it can be treated at both ends, tip and bulk. It's really important to maximize the medical treatments that you're on, and make sure you're on essential ones. But remember, they are mostly allopathic. They're aimed at treating symptoms. One thing at a time is best. Give each new thing a month and then decide, is this working? Yes or no? Unsure. If it's no or unsure, stop it. Make sure that what you're taking is essential. Now, it's more important, even so, in the long term, to maximize your mitohormetic strategies, okay? This is salutogenic or healing-based. For each strategy I've mentioned, it's essential to pair, when you do a diet or an exercise program, pair that stressor phase with a complete recovery phase. If you don't pair them and have the stress and recovery combination, you won't get the benefits as optimally as you could. Last, every day, pursue goals, especially a C goal. Thanks a lot, and those are my references.
Matt, thank you. Thank you very much for this. And I really like the C goals. It reminds me of what Mark Twain once said. He said they didn't know it was impossible, so they did it. And I think that there is something there to it, is that if we were not told that it is degenerative, chronic, you can't do anything about it, we might be able to do more to help ourselves with
That's
it.
That's right.
So thank you very much. Let's just look at the questions we have had while you were talking. In passing, I think that if you have put your questions, I'm talking to the audience here, if you have put your questions in the chat, please can I kindly ask you to cut and paste them to put them in the Q&A, because I'm looking at the Q&A, not necessarily at the chat that is monitored by Mark. So first of all, a little comment. Audrey listened to us as we were preparing for this webinar, and she's saying that you would be very well received at the next World Parkinson's Conference in Phoenix. And I think Audrey and I are both from the UK. We met in Barcelona 3 years ago or 2 years ago. And, okay. And I think that she agrees with our assessment. Someone anonymously is telling us that his doctor or her doctor says that extended release levodopa doesn't give dependable results and won't subscribe it for me. Is that anywhere near accurate?
Well, yes and no. A lot of doctors rely more on the immediate release levodopa because it is slightly more dependable. But I think a lot of the problems with extended release is lack of experience with it might be a factor. When you use, as a doctor, immediate release more, you get more familiar with it and you get better at managing the complications. And it's a matter of not trying something that you're not familiar with. I think in my experience, extended release can be really helpful for some people. So although the evidence may not be as strong in terms of reliability, some people it's very useful. And yes, some people it doesn't help that much. But I think a lot of the things also is like meal timing. You know, you got to be more careful with your meal timing, for example, with the extended release. Make sure you're using that extended release mainly at nighttime. It's better as a nighttime thing because you don't eat during the night. And so I guess, yes, I agree with that somewhat, but no, in my experience, extended release can be very good as well.
Thank you, Matt. And my personal experience, if that's worth anything here, because I know that we all have a different variation of Parkinson's, but extended release has really helped me with sleep. This is not the only thing that helps. There is another set of other things, such as THC and CBD, but extended release levodopa has been a life changer, a lifesaver for me, especially when you talk about the importance of sleep to recover from stress. Sue is asking about citicoline. She says that she has heard positive things and it crosses the blood-brain barrier.
Which one was that?
Citicoline, citicoline, C-I-T-I-C-O-L-I-N-E, citicoline.
I'm sorry, I don't know much about that one. I can't comment. My apologies.
I'll let you look it up, actually. It has been prescribed to me by a naturopath in the US, so I'm taking it, but that's why I was keen to hear your answer. But clearly it is not as mainstream as Sue and I may be thinking. Julie is telling us that she had a gastric bypass surgery 20 years ago. And she's asking if she needs to consider anything special when it comes to diet or medication timing.
Yeah, that's a good one. The people who have had operations on their stomach. Look, you often will have to alter your dietary feeding pattern in order to compensate for that. So that might make it harder to have like OMAD 1 meal a day or TMAD 2 meals a day. But you could still use the eating windows, like 8 hours of eating a day. You could maybe throw in multiple smaller meals. I don't like that as much, but it's doable. And of course, people who have had that procedure, the fasting protocols become even more important, right? You can still fast absolutely fine. So I would say maybe focus more on your what's my fasting protocol if you have those, and make sure that you might have to tailor what I've said and throw in an extra meal or two throughout the day.
Someone is telling us that he or she has been told that the keto diet isn't safe in the long term. I know you disagree, but do you want to add something? Because that person is asking whether studies have addressed the long-term keto use, not just for a few weeks, but for many years, for instance.
Yeah, great question. The answer is no, but that's because there's no population in the world is on their ancestral diet anymore, other than those modern hunter-gatherers I showed, and it's absolutely safe in them. They don't get Parkinson's, right? So what they said is not quite correct. But that being said, yeah, almost all of the world is no longer on a ketogenic diet for agricultural reasons. There are people, I've been on a strong keto diet fasting protocol for 10 years. I'm not dead yet. Feel like I'm doing pretty good. So there's anecdotal evidence like that. But, at the end of the day, to do a proper interventional study, there's no evidence that the modern diet is any good either, that it's not harmful, right? So show me a randomized controlled trial of the standard diet that's lasted 5 years or 10 years or 15 years where they compared it with another diet. So it's kind of a thing where it's hard to counter that argument, but the argument itself is a bit too purist for me, and expecting an interventional trial of 10 years is silly, and there's no big populations eating these now to compare against, so it's difficult.
So Char has quite a long question here. I'm going to try to extract the essence of it. He has struggled with digesting meat when trying keto diet, and it seems to worsen gastroparesis. Now, he can eat a range of all other things, but no grains. And he's asking whether you could recommend anywhere to look for guidance. He's making a very important point. Unfortunately, he has found neurologists are generally uninterested in dietary considerations as a treatment for PD, and I agree with that.
Yeah, this is an interesting topic because a lot of people are very pro-carnivore, and then there's people who are pro-vegetarian, and I'm pro either as long as it's keto. So if you have trouble with the meat, first of all, figure out what kind of meat gives you the trouble. Some people have trouble with red meat, but they're okay with chicken, or they're okay with fish, or they're okay with seafood. So you don't have to be having red meat, steaks and lamb and things like that. So experiment with different meats. If it's all meat, then make sure your hydration is on point, and then try those sparkling water or coffee supplements when you eat. As I said, that can stimulate the stomach and improve your gastroparesis. It works in a lot of people really well. Try that. And make sure you're hydrated, make sure you have enough salt on your meat. And then if you're still having trouble, you don't have to have a lot of meat in a keto diet. You can have a lot of there's a lot of great high fiber keto recipes where you emphasize on nuts and seeds and things like that that really get the bowels moving well. I have a lovely keto porridge recipe and a keto nut loaf recipes in our plans that are really, really good at this, and they're not meat-based. So you don't have to have large amounts of meat. The pyramid I showed you was a meat-based omnivore diet because I think that works really well for a lot of people, but maybe not everybody.
So someone is asking, how bad is fruit? Because he or she craves fruit and loves it, like me.
Yeah.
My breakfast in the morning is only fruits. So when I listened to you, I just thought, my God, I've been doing it wrong for so long.
No. So it's so common in Parkinson's to love fruit, because with Parkinson's and Alzheimer's as well, you get a sweet tooth as the condition progresses. And probably that's the brain telling you to eat more sugar because that's going to give me energy in the short term. But in the long term, of course, that's probably feeding the problem. That's why ketones are good, because they're long term. So the trick is to get over what we call this sort of sugar addiction. It's a carbohydrate addiction that most people have because we have so many carbohydrates, and it's the craving of the sweet taste that's the problem. And so what I'm saying is the fruit doesn't belong in a ketogenic diet. You can have some berries and things like that, but not too many. So the fruit doesn't belong in a keto diet, and I think the keto sort of approach is the best. It's going to be proven to be the best, but it's going to take more time and data. That being said, a high carb, low fat diet, like our other diet in that Parkinson's trial, is not so bad if it's high carb, low fat. So you have lots of fruit, vegetables, and grains, but keep the fat really low. That mitigates that metabolic gridlock pretty well too, right? The mitochondria can metabolize that pretty well too. Long term, it's not as good for various reasons as high fat, low carb, but it can be okay. So first of all, if you love your fruit and you want to really keep your diet with high fruit, get the fat low, okay? Get the fat low and make sure you have lots of fiber, lots of fiber. That's a pretty decent diet. But if you want to maximize it, low carb keto, you're going to have to find a way to reduce that fruit intake and just stick with some of the good fruits, the berries in particular. And that means overcoming the carbohydrate addiction. And that takes a few weeks, few months, arguably. And you might need some sort of strategies and a guide to help you do that. A low carb clinic online, it would be my recommendation.
Thank you. Linda is asking about Crexont. Now, Crexont is available in the US, but not in the UK, unfortunately. And I think it does have some benefits versus standard Cinemet kind of levodopa drugs.
That's a brand name, I think. So
yes.
How do you spell it?
Crexont.
Yep.
Crexont. Crexont.
Just looking it up now. So that's carbidopa, levodopa. That's the same as our Cinemet. That's the exact same as our Cinemet. It's just a brand name. So the generic name is levodopa, carbidopa. The brand name for New Zealand is Cinemet. The brand name for your country is Crexont. So anything I said about Cinemet applies to that medication.
If I'm not mistaken, I think Crexont has a longer effect than levodopa, the 3 to 4
Does
hours.
it?
I think Crexont does better. But as I said, it's not available in the UK where I'm based, so I have limited information.
Yeah, sorry, I don't have any practical experience with it, so perhaps I shouldn't comment about it too much.
No worries at all. Steve is basically saying that he didn't see any mention of a 5-to-2 diet. And does that create too big a gap between stressor and recovery? And what about fasting 2 separate days a week, for instance?
Yeah, no, that's a great combination as well. I just didn't mention it in my list because I don't utilize the 5 and 2 approach much. 5 and 2 is eating 5 days a week pretty much normally, and then 2 days you fast or you have a very, very reduced intake. That can be very good. I guess I prefer a daily fasting regimen and implementing. When it's every day, it becomes habit very easily. I think it takes longer for things to become habit in 5 and 2 and longer fasting protocols because you're not doing them every single day. When you do a 12-hour, 14, 16-hour fast every day and you make it part of your lifestyle, it's so easy for it to become habit. And then you don't have to, it's not hard anymore. It's just what you do.
Thank you very much. Suzanne is asking whether your recommendations are equally valid for men and women. And she understands that most clinical trials are done on men, and PD symptoms are not the same. Women, for instance, according to Suzanne, have more tremors than rigidity.
Yeah, very good point, Suzanne. So yes, things do differ a little bit. And I have noticed that it is, the keto diet is done well by both women and men, but the fasting is harder on the women. It seems harder for them to do that. And I think evolutionarily that makes sense. Women would have been gatherers, men would have been hunters. So gatherers would be more used to having multiple meals, whereas hunters would, you go for a few days running down your prey and then you have a huge feast kind of thing. So, but yes, I have noticed it's harder. So women, I would say it's still important for these metabolic therapies. However, I would focus on shorter fasts rather than longer ones. And at the end of the day, listen to your body, man or woman. If you think, I really want to do, just a 12-hour fast every day and no more, go for that and just stick with that. But if you're like, yeah, I want to do a 1 meal a day strategy, and then maybe I even want to do like a 4-day fast, get some guidance, but then go for that too. So no matter who you are, listen to your body and go for it.
Thank you. Charles has a great question that I would not want to get for an exam. He says, many diseases have mitochondrial dysfunction at their core, including Parkinson's. What makes Parkinson's different?
Okay, so I wrote a paper with this with my colleague, Dr. Martin Picard, who's a mitochondria specialist at Columbia University last year. It's called Neurodegenerative Disorders, Metabolic Icebergs, and Mitohormesis. I'd encourage you to look at that paper. In that paper, we talk about the 4 most common neurodegenerative disorders: Alzheimer's, Parkinson's, ALS, or motor neuron disease, and Huntington's, and how mitochondria damage and disruption can result in all 4 of those disorders. But the way the mitochondria are damaged is different. One of the key factors is that the mitochondria are different in different brain structures in different parts of the body. These are called mitotypes. So in Parkinson's, the mitochondria that are affected are those in the substantia nigra and basal ganglia regions. They are different from the mitochondria that exist in, say, the hippocampus and cortex, which are the structures that Alzheimer's hits, right? So the risk factors that I showed you, the triggers and all these things, somehow disproportionately affect the mitochondria that are important to those structures that cause Parkinson's, as opposed to the risk factors, which slightly differ. There's overlap, but the risk factors slightly differ with Alzheimer's and ALS and Huntington's. So different risk factors will give you damage to those mitochondria. That's the essence of it. But if you want to read that paper, that would be the best way to really answer that question. Thank you for that question. It's a good question.
Thank you much for the answer. Very comprehensive answer. Marilyn is asking whether a keto diet affects the gut microbiome.
Absolutely, it does, and fasting does too. Bulk of the evidence would suggest that. Some studies don't, but yes, it does. So the trouble with the microbiota is that we don't know enough about it. So people don't even really know what a good microbiota is. We probably know that more species diversity is a good thing, and a certain mix of bacteria is a good thing, but there's a lot of fuzzy lines there. And so when we talk about gut health and what's the ideal microbiota, the actual answer is nobody knows. So rather than analyzing the microbiota yourself, or sending off stool samples and having them analyzed and stuff, I think we need to wait for the research to catch up on that one. I would just say, again, listen to your body. If the keto diet is not giving you any gut problems or even improving them, such as constipation or bloating, then that is a good thing. If you're getting problems, I would suggest most of the time you're not doing something right about the keto diet, and it's so easy to do things wrong. And when you fix something that's so simple, a guide can really help you, someone else. So I would look at that. But we have to wait for the evidence to catch up on microbiotas.
Thank you very much, Matt. Better has a great question, actually. How do you manage weight loss with keto diets, and how do I keep weight on? How important is BMI, body mass index?
Yeah, so most people now are overweight or obese. So in New Zealand, we're about 70% of the country is overweight or obese, body mass index over 25. So for those people, the benefits are obvious, right? You will lose the weight, which is what you want. Remember, though, all the other benefits I showed you in that chart, the LDL chart, there's a lot of other benefits, and you're doing this for your mitochondria in your brain primarily, not your weight. Now, some people with Parkinson's do have a very low BMI, or they're even under a BMI of 20. I have had that. I will admit it is harder to adopt these strategies, okay? The initiation period is a little trickier. Now, that being said, these people, when you do this, they will lose some weight at the start, but not nearly as much as someone who's overweight. Someone who's overweight will lose a lot more weight, which makes more sense. So it's during the transition phase when you might lose 2 or 3 kilograms or something, and that's concerning to people. They don't want to lose weight if their body mass index is already 18 or 19. However, there are ways to do it. So I would say, think differently. The carnivore ketogenic diet for Parkinson's might be a good thing, right? You jack up your protein and your fat. It's a lot more protein, and you sort of go with a very easy fasting protocol to start. That's one way to approach it. Or just going omnivore diet and punching up your protein. So getting your protein up and making sure you're timing things well. That's another way to do it. Keeping the fasting protocols short. Making sure your hydration and salt intake is good. There's a lot of reasons that one might lose weight that are not related to the diet per se. And so again, having a guide is very important for you. Again, a low-carb clinic online or not is probably the way to go. These people, someone who's experienced in starting people on these things is probably the best way, because even with people with low weight, I find you can do things that can help them. And then you can even try things like, I haven't mentioned it today, but you can do this thing called a cycling ketogenic diet, where you introduce small amounts of carbs, like once or twice a week, not a lot, but small amounts, to try and stimulate muscle growth and weight regain. There are strategies that can be tried. Okay, it's a fascinating what you can do, but it's not an absolute indication unless you have like anorexia nervosa or something like that. But that's a brain disorder. That's not just a weight loss disorder per se. Yeah.
Thank you, Matt. Troy is asking about sweeteners like stevia, for instance. Do you recommend them, and do they affect ketosis?
Okay. Short answer, I don't recommend them, and yes, they do affect ketosis. Now, that's nuanced. I do have a little bit of sweetener in some of our recipes for people with Alzheimer's and Parkinson's to try and help get over the sugar carbohydrate addiction, the sweet tooth. So I think small amounts of sweetener is probably fine. I don't have a purist approach on many topics, if anyone who knows me is aware of. So I think having small amounts of sweeteners is okay. You'll find with time, like I know for myself, I used to have keto desserts myself in the first 2 or 3 years, and more sweetener. Now I don't even touch the desserts. I don't want them. I don't even want the sweetener. So once you stick with these things for months or years, you'll find your craving for the sweetener goes down. So if that's what it takes to help you adopt a ketogenic lifestyle, then use it. That's absolutely fine. It's better than sugar. It's not ideal, but it's better than sugar. So use it, and then recognize that in a year things might change. So you don't have to start everything perfect. You can start things in a sort of non-perfect manner and just stick with it and work out the problems as you go, and that's the important thing.
Thank you, Matt. That makes sense. Maybe on a transitional basis as you progress towards your end target or your long-run target. Someone is asking us about exercise. He or she says that, let's just assume he exercises every day, runs 3 times per week, gym 2 times, boxing, etc., etc. I recognize myself in that. And he's asking, is it too much for mitochondria? And the second part of the question is, could ultra running and racing, like people who go for very long distances and training for races 7 times a week, like really go crazy, could that kind of program have triggered a PD that was maybe already potentially there, but was triggered by that?
Yeah, there's a lot in that question. Excellent question. Thank you. So we know, so of the 4 major neurodegenerative disorders, only one has been where excessive exercise is definitely linked to the etiology of the disorder. That's motor neuron disease. That's why it's also called Lou Gehrig's disease, right? It hits professional athletes disproportionately. So excessive exercise, not recreational, but ultra athlete level, professional level, is a strong risk factor for ALS. It's not been shown to be a strong risk factor for Parkinson's, but that said, I think excessive exercise will damage the mitochondria if you don't give them recovery. Now, if you're doing that training program 5, 6, 7 days a week because you love it, and maybe it's one of your A, B, or C goals, then I'm not going to argue with that. You should do it. But recognize, although it may be making you fitter, stronger, faster right now, in the long term, yes, I think it will damage your mitochondria. Yes, It will damage your health, yes, in the long term. Okay, ultra athletes get more health and medical problems than recreational athletes. We know that. They get more heart problems, they get more kidney problems, and so on. So the numbers are there. So I would say if you are really loving this lifestyle, sounds like you do, then the love itself is enough. What we love kills us eventually anyways, so don't stop. But if it's truly health that you're concerned about, you're exercising too much. Yes, I would go taper it down to 3 days a week and give yourself proper recovery on the other 4 days using the sleep and deep rest protocols I mentioned.
Thank you very much, Matt. Just a couple of words to our audience, just to say that we have another 10 minutes for this webinar. So I will take as many questions as we can, but I would just ask you to perhaps start refraining from asking more questions at this stage, because we will not be able to, as we're never able to answer all questions. Mark is asking us whether the recordings will be available for this talk. Yes, Mark, they will be either tomorrow or the next day. So you will be able to follow that afterwards or share it with people. Someone has a great question. How do you socialize, which is healthy, and go out to dinner with friends on a low-carb keto diet? You take them all to a keto restaurant that exists.
Yeah, it depends on the country. And so we're lucky to be in New Zealand where it's easy. Look, it can be hard, particularly if you're in a country where the ethnic cuisine is strongly carbohydrate-based. But I would say in that case, the meat is your friend. It's hard for restaurants to screw up meat, right? So they often put sugar in sauces. They often put sugar in funny little places you'd never expect it. So if you go to a restaurant, if I go to a restaurant, I'll just order the meat. If I can avoid any sauce they have, I'll do that. I'll sometimes bring my own bottle of extra virgin olive oil, or most restaurants have butter. So you can just say, I want a steak and I just want butter on it, or I want this meat, butter. So that's a way to stay strongly keto. And you don't have to have meat and butter. You know, if you're having a breakfast or lunch, it's easier. You can just order sides. So don't order any of the meals. Just say, I want sides. I want eggs. I want bacon. I want hollandaise sauce. Maybe a bit of avocado. It's quite straightforward. That being said, some restaurants, it's more challenging. And in that case, you might just have to accept that all you can do is go low carb on that particular evening. But, you know, the occasional low-carb meal on a keto diet is okay.
Thank you very much. Ken has a great question. He's asking whether cold water showers work in mitohormesis therapy. Does it stimulate the mitochondria? I'm sure it does, but does it provide relaxation afterwards?
Yeah, great guy, great one, Ken, absolutely. So if I was going to put a sixth thing on that chart about the modern lifestyle, it would be excessive exposure to ambient temperatures, and that mitohormesis can be activated by both periodic short exposure to cold and hot. So I'm a fan of the cold showers. I have one every second day myself. I'm a fan of ice baths. I'm a fan of sauna therapy as well, which I do after my own exercise sessions in particular. So yes, definitely cold and hot temperature variation will activate mitohormesis. I didn't put it in there because I think the other 5 are more important. But if you feel good on those 5, yeah, do that.
Someone said that you mentioned recipes, and is asking whether there are resources available with such recipes. I think you mentioned something when we spoke 2 years ago. I can't remember for sure. Wasn't there like a web resource that you mentioned?
Yeah, I have a metabolic strategy plan on my website, which is metabolicneurologist.com. If you go to that site and click resources, there's a metabolic strategy plan, which has a number of recipes that are pretty guaranteed to get your ketones to the 1 or 2 level and keep them there in almost everyone. And that being said, that plan itself is 2 or 3 years old. I'm going to update it in the next year or 2, but for now, it's still pretty good. So you can go there and download it for free.
I just wanted to say to our audience that when we post the video on our YouTube channel, in the comments, in the description of the video, we will put your email, your website address so people can easily track it. Philip has a great question. He's asking whether the health of mitochondria can be measured, for instance, under a microscope or other instruments.
That's a really great question. So mitochondria do so many things. They coordinate the energy and cell processes in general, right? They're arguably, to me, the fundamental unit of life within us. We can measure them many different ways, like a little bit here, like on those 6 levels, within each level, there's categories. You can measure bits of each of those 6 levels, like you can look at the activities of certain enzymes and molecules that the mitochondria use. To comprehensively assess their health, nobody has the answer to that yet. Dr. Martin Picard, the colleague I mentioned, his team at Columbia, they're trying to come up with stuff like that, and maybe one day we'll have it. But it's a lot more than just, oh, this enzyme gets better, or the mitochondrial content in the cell gets more mitochondria. This is a very basic and insufficient way to look at it. So right now, no, we don't have a good assay. So my studies that we're doing are looking at mitochondrial improvement indirectly by looking at the symptoms, the tip of the iceberg. And if the concept of the iceberg is true, then a lot of it's because of improvements in mitochondrial health. So I hope that answers your question. Maybe in 30 years, if medicine becomes much more mitochondria based, and that's exciting to me. I think a lot of people are starting to think this way, that we'll have something, but right now we do not.
Excellent, thank you, Matt. Sue is asking whether you do have a keto-based clinic at your hospital that is web-based. In other words, can people reach out to your clinic to get advice, consultations?
So the answer is no, I do not. I'm fully public neurologist, and if anyone knows how the public system is in New Zealand, it's very short of doctors in general. So, but also I don't want to have a financial conflict of interest, and that's why I haven't got a keto clinic or metabolic clinic in general. So I don't have anything, and I don't have a private practice. So I usually refer people on to a couple of low-carb clinics locally for that. There's one in Sydney that's good, and one in New Zealand that's good down in Taupo. But I'm happy for people to, I do answer emails, so you can get my email address on any of my papers and email me if you have any specific questions. And I try to answer all of those to the best I can. Yeah.
Well, we will answer a few more questions, but I just wanted to echo what you just said to everyone who was actually listening and taking part today. For those of you whose questions have not been answered, it is really by lack of time, or sometimes because what you described was such a specific personal situation that I did not prioritize it, given that I want to have questions that benefit the vast majority of the people attending. So you can always contact Matt through his email address, which is available on his research papers, as you said, maybe on your website. So Javier has a great question, actually. He's asking about exogenous ketones and how efficient those can be.
Yeah, good question. Look, I'm neutral on those. I do not use them, and I do not prescribe them. Why? I like endogenous ketosis. I like the person to produce the ketones themselves. I think that's important because there's so many more benefits to the ketogenic diet and fasting protocols, the metabolic therapy, than the ketones themselves. The ketones are reflections of all the good changes that are occurring to a lot of enzymes in the mitochondria, right? So I don't think the evidence is suggesting that exogenous ketones can really enhance mitochondrial health to any great degree. And it's like methylene blue and those things, and red light therapy. They can help enhance mitochondria, but they don't activate mitohormesis. So they can enhance things a little while, but you have to keep taking that thing in order to get the benefits. There's mitohormesis is all about inducing long-term changes, and I think endogenous ketosis is the key there.
Thank you. I have a question from Mark, who basically is referring to physical pain. For him, it is in his shoulder, and he doesn't respond to levodopa medication. He's asking whether in your clinical experience, have you found any intervention to be effective for people who suffer from pain in parts of their body, in Mark's case, his shoulder?
Okay, there's 5 major pain syndromes in Parkinson's. The frozen shoulder pain is the most common, followed by sciatic pain. So this is a real common complaint. Now, the first thing is to get proper imaging of the shoulder and make sure there isn't a structural problem that an orthopedic surgeon can help you with. That's key. Don't assume it's the Parkinson's. It may not be. Now, if the imaging is okay, then it probably is the Parkinson's. Now, levodopa can help with that if it's done correctly. So then I'd say make sure the levodopa is being timed and dosed and meal timed properly in order to get the maximal effect. You may not be getting the effect. Now, if that is the case, then it gets harder. Keto diet fasting protocol can help. The metabolic therapy did help pain syndromes in our trial quite a bit. And so all the approaches I'd mentioned, I think I would start trying them, including some of the off-label and even the devices, but might help with pain. Just try things for that if the medications are letting you down. It's hard to say what will help you in these sort of treatment-resistant cases. Just keep trying stuff. I would be trying different things if I were your neurologist. But first of all, I'd get the imaging to make sure you don't have a rotator cuff or bursitis or something there that can be easily fixed.
Thank you, Matt. The last question is also a suggestion from someone who basically says that there are a number of people with Parkinson's on keto, low-carb, fasting diets who basically have gotten the benefits that you mentioned in your presentation today. So basically whose diet was very helpful to. And he basically is asking whether there is any way that a database of these people could be established in a sense to allow them to enter the data and to allow us to sort of like be more formal about how those diets can help many people with Parkinson's, if you want, without going into a trial. So is there a way to capture this information, allow people to enter the information? I don't think that system exists, but could you envisage a world in which we could create a system by which the many people around the world who are using different diets and find them beneficial could enter the data to allow us to be a bit more scientific about the vast effect it can have?
Yeah, that's a great idea. I hadn't thought of it. It does not exist, but it's a good idea. So maybe it should. We'll leave it at that. Yeah. Thank you for the comment.
Well, thank you, Matt. I think that it is 9:30 here, so we've been going on for an hour and a half. I think this is long enough. Otherwise, we'll have people falling off and going to bed in different parts of the world. But Matt, thank you. You won't go to bed given that you started at 7 a.m. in the morning. So thank you very much for being available to us today. It is hugely appreciated. And I would just say that beyond the time that you give us today, thank you for the time you give to the Parkinson's community every year of your life, if you want, because it's really very important to all of us. So thank you for the research you do. Thank you for the solutions you bring to us. And I hope to meet you in Phoenix next year.
Yeah, let's make it happen. Thanks a lot, guys.
Thank you so much. Thank you, everyone.